Good afternoon, everyone. Dr. Hughes, can you hear us?
Yes, can you hear me okay?
Yes, your audio and visual are great. We will be doing a little bit of our housekeeping, then I will turn the table to you after the introduction. All right, so it's noon Central Standard Time. So good afternoon, everyone. We have a very special guest today, all the way from Baltimore, Maryland, from the prestigious Johns Hopkins Children's Center. Dr. Hughes, welcome to TexLa TRC telemedicine webinar. We are very happy to have you here. And with me, as a co-moderator, is the student from the Student Interest Group, Kaja Siddiqui. Kaja?
Nice to meet the both of you, and thank you for joining us. This is an educational activity sponsored by the project of TexLa Telehealth Resource Center. It's a federally funded program with F. Mary Hall Rural and Community Health here at Texas Tech University Health Science Center, as well as Well Ahead, Louisiana, with a generous support from Health Resources and Services Administration, or HRSA. Dr. Santos?
Yes, thank you, Kaja. We would like to thank Laura Lappy, as well as Max, who worked hard to make this telemedicine Project Echo series part of the internal medicine grand rounds. We sincerely appreciate Dr. Shermer for the opportunity, and Daniel Stewart, our resident medicine librarian, who will be typing on the references of Dr. Hughes in the chat box. Kaja?
There are some helpful tips for our webinar. Make sure all microphones are muted. Also, kindly type your name and email in the chat box, as well as any questions or comments. Make sure you fill up the session evaluation to obtain those CME credits. To help introduce our guest, Dr. Santos.
Yes, our special guest today is Dr. Hughes, who serves as Associate Medical Director for Johns Hopkins Medicine's Office of Telemedicine and Medical Director of Pediatric Telemedicine for Johns Hopkins Children's Center. Dr. Hughes is an Assistant Professor of Pediatrics at Johns Hopkins University School of Medicine, and attended Hopkins as well for medical school. And she received her Master's of Public Health from Johns Hopkins Bloomberg School of Public Health. She completed her residency in pediatrics and served as chief resident at Johns Hopkins, where she stayed on to complete a research fellowship in general academic pediatrics. Dr. Hughes is the co-editor of Harriet Lane Handbook, which I actually used when I was in med school back in the Philippines. She previously served as Associate Program Director for Pediatric Residency Training and Director of Pediatric Residency Program Health Equity Track. As an administrative leader, researcher, and clinician, Dr. Hughes wants to use digital health tools to improve access to care and quality of care for typically underserved patient population, and learn how telehealth can be used to enhance patient-centeredness and timeliness of care, delivery of care without sacrificing safety and effectiveness. Without further ado, let's all welcome Dr. Helen Hughes. Dr. Hughes.
Great. Thank you so much, Dr. Santos, and the organizers for the invitation, and to Laura for all of her organization. I'm going to go ahead and start sharing my slides. Does that sound okay?
Sounds great.
How does this look?
Sounds perfect. You can
Looks
go ahead.
fantastic. Excellent. So again, thank you so much for the invitation. Don't have any relevant disclosures for this presentation. And I know this is a diverse group, I think, some pediatricians and some non-pediatricians, but I'm hoping to give you all a sense of the indication and application of telemedicine in pediatrics, some special considerations, as well as future directions, and knowing about some national resources for pediatric telemedicine. And definitely happy to answer any questions in the Q&A as we go along. So just a little bit about my story and my intersection with telemedicine. So I work in East Baltimore. I actually just got out of pediatric primary care clinic. I work in our resident training clinic. This is a picture from the Harriet Lane Clinic here on the left where I work in East Baltimore City. And around 5 or 6 years ago, actually, I did not have that much of a positive association with the term telemedicine or telehealth as a general pediatrician. I thought a lot of it was kind of the direct consumer telehealth that I, heard about in the news and thought, yes, maybe it's access for patients, but maybe it's taking care outside of the medical home. I didn't necessarily have a great association. And then I started about 5 years ago to learn about Project Echo, actually, and a lot of what was happening in the middle of the country in terms of access to care using telemedicine, Indian Health Service, other kind of historical programs. And I really started to have a different mindset of, really this is a tool to connect providers and patients. And wouldn't it be great if my patients in East Baltimore could have access to this tool because they have a lot of barriers to coming to clinic. So that was, the past during that time. So this is a publication from 2019. Kristen Ray at Pittsburgh and her team, were doing some investigation and research into direct-to-consumer telemedicine and really had concerns that, maybe there were concerns around not as high quality care or care being delivered and maybe not having the same care as you would in person. And there were a lot of companies pre-COVID that were growing that were trying to get patients easy access, but there were maybe concerns that some of these companies were raising a lot of capital, but maybe was too easy access for patients. So there was kind of this double-edged sword of a lot of great programs improving access to care, but then maybe some other programs that left to be determined how high the quality of care was. But in Maryland at the time, so this was 5 years ago, we, being a mid-Atlantic state, not a place that has a ton of rural areas, but we do have rural areas, there wasn't a lot of momentum to build telehealth programs here. Maryland Medicaid didn't cover it when patients were in their homes. They had to be at certain originating sites. And our clinics were already full. So there wasn't a lot of momentum to do this. And I led a very small pilot program in 2018, partnering with the health department in rural Maryland to try to get patient specialty follow-up. But there were lots of legal, logistical, regulatory barriers to kind of getting that program off the ground. So that was, again, pre-COVID. And some of you may be familiar with the work out of the AAP group Sprout, which is supporting research and outcomes and utilization in telehealth. It's a great acronym. But they get a landscape in 2018 pre-COVID of about 60 telehealth programs across the country. So some of these were outpatient, some were inpatient. And, there were pediatric telehealth programs in almost every specialty pre-COVID across the country. About half of them in blue were established services and about half in orange were pilot services. But there were a lot of barriers to getting it off the ground this was the providers who were surveyed, the barriers that they were discussing, regulations, patient preferences, training, licensing, technology connectivity, reimbursement. But if you summed, one of the biggest barriers was providers wanting to do it. So providers not having enough time to do it, not really being interested or not being interested either at the distant sites where the provider was or at the originating site where the patient was. And so what was amazing about COVID is all of a sudden everyone wanted to do it, as I'm sure many of you experienced, and kind of these barriers of just the inertia of, well, I'm too busy, I don't want to try something new, kind of melted away. So that's really been amazing to watch. And I apologize, I'm not familiar with how, if everyone's on the same page about the regulations that change, so I'll just overview them briefly. From a pre-COVID standpoint, particularly in Maryland, and just speaking about my patients, there were many regulatory barriers that made telemedicine in the outpatient setting difficult. So many private insurance companies were covering it pre-COVID. For instance, a patient with Blue Cross Blue Shield who went to one of our more affluent area practices could have an ADHD follow-up or an asthma follow-up for telemedicine pre-COVID, and it could be reimbursed. But because the providers in those clinics could only do it for certain patients with certain insurances, and they had to look it up, it was really challenging for them to integrate it into their day-to-day practice. But most state Medicaid programs, I'm fairly positive Texas from my review of some of the websites, as well as Maryland, required that the patient not be at home, unlike private insurance. So the patient had to be at certain sites pre-COVID, like a school-based health center or a community health center. And Medicare had that restriction, patients couldn't be at home, they had to be at a certain site. And they also had health professional shortage area restrictions. So you had to either have a certain condition like end-stage renal disease, or you had to be in a certain rural area. And for an academic institution like Hopkins or like your own, it's hard to operationalize something when like you can only give it to a very small slice of your patients. The barriers to entry are really difficult. There are also provider location restrictions. So providers couldn't be at their own homes. They had to be at certain distance sites that were certified. Not all providers could do it. So in Maryland, it was mostly physicians and advanced practice providers, but not occupational therapists. The practice of medicine, which is still true today, is based on where the patient is. So there are across state border issues. And then technology-wise, there had to be really specific HIPAA compliant platforms. So some of these went away with the pandemic and some of them have stayed. I'll get to that in a little bit. But just finishing up the past, because of these restrictions, a lot of the pediatric telehealth that was going on pre-COVID was actually school-based telehealth. So let's get the children where they are. They're in their school day. And so two of the biggest places that were doing that work pre-COVID were University of Rochester and New York State. Jill Halterman had a number of NIH grants looking at school-based telemedicine for asthma specifically. So they would do follow-up visits with children and then teens in school for their asthma, make sure their asthma controllers were appropriately dosed. And they showed in this randomized trial improved, reduced ED visits and improved symptom-free days in patients who were randomized to a telemedicine intervention back in around 2016. And then this is from 2019 from the Medical University of South Carolina, who had a big state-funded, who had and have a big state-funded telehealth program aimed at improving rural health in the state of South Carolina. And they did a paper looking at comparing a county that participated in their school-based health program with surrounding counties that did not. And they showed children in that county had, with asthma, had reduced ED visits as well when participating in the school-based telehealth program. So that was kind of the past for pediatric telehealth. It was, not very commonly integrated in pediatric primary care, perhaps outside of Kaiser, which I'll get into in a second. It was kind of individual targeted programs to underserved populations, a lot of school-based programs, particularly in Maryland, which has been my experience. But really what happened in the pandemic is a lot of those barriers that they talked about in that Sprout article went away very quickly. So Medicare and state Medicaid programs put in waivers and said, we will cover telehealth wherever the patient is, even if they're in their home. They said the providers could be at home. They said all types of providers can do it. And then briefly for about the first year to year and a half of the pandemic, many states put in waivers to say, it's okay, you can see a patient that's in our state, even if you're not licensed here, although a lot of that has gone back to the pre-pandemic state. And then from a technology platform standpoint, it used to be that telemedicine was only two-way live audio visual, and that was what could be reimbursed. But the government and the payer said audio only is okay. If you can't connect on video, you can still bill over telephone, and you could use FaceTime, like a non-HIPAA compliant platform if you needed to, and there would be no ramification to you from a HIPAA enforcement standpoint. So the cross-state licensure is kind of back to the pre-pandemic state, and the audio only, platform issue is kind of back to the pre-pandemic state, but a lot of these other ones still are kind of in the pandemic era state, making it much easier to provide outpatient telemedicine services than it was before the pandemic. So this is the very high level telemedicine story at Johns Hopkins, which is probably very similar to other institutions. But really to emphasize pre-COVID, which is here on the left, we had almost no outpatient telemedicine. Again, we're in the mid-Atlantic, we don't have a lot of rural health, and so we had fewer than 600 total outpatient telemedicine visits in the 8 months prior to the pandemic. We did have an office of telemedicine for about 3 to 4 years prior to the pandemic who was trying to get things started, but because of all these logistical barriers, it was really based on individual champions who were willing to start a small individual pilot program. But then overnight, we were able to switch a lot of care to telemedicine. Blue here is video visits, and orange here is telephone visits, which have gone down, but now we're kind of at the steady state where around 15% of our outpatient care to this day is via telemedicine with almost 1.4 million visits. And this is a graph comparing our in-person care in orange to our telemedicine care in blue, showing again that kind of we had this in the beginning lockdown stage of the pandemic, rapid decrease with a rapid increase in telemedicine, and that in-person services plus telemedicine services have really, this yellow line is our 10-day trailing average, and this gray line is our pre-pandemic baseline of outpatient volume. And essentially the averages are following along that baseline. So we're seeing that telemedicine has sort of been a substitute for some amount of in-person visits, but hasn't created a ton more care. And then this is again across our whole health system, and sitting in where does pediatrics fall here. This is just looking at telemedicine sensitive visits or visits in specialties that could be done by telemedicine. So not lab visits or radiology visits. And, you know, this is JHM total here in the middle. The blue bars are the first half of the year 2021, and the orange bars are the second half of the year 2021. And we hear a lot about primary care and behavioral health, so certainly psychiatry has been a plague player, but we also see a lot of our visits as nutrition, genetics, pre-op, post-op care, neurology, neurosurgery, and internal medicine. Particularly for neurology and neurosurgery, a lot of patients can't drive if they've had a seizure or a stroke or a neurosurgical procedure for 6 months after they've had their procedure. And so they've found that they've really found it to be a valuable tool for providing care. Pediatrics has been kind of in the middle, when then here with 12% of our outpatient pediatric care, that's both general peds and specialty in the second half of 2021 being by telemedicine. And then we feel a lot of our proceduralists don't use it as often because a lot of their appointments are involving a procedure which needs to be done in person. And then this is a graph of the kind of volume in bubble size of our different specialties, you know, over the past 2+ years. And we've seen almost every, or I would say every pediatric specialty at Hopkins doing some sort of telemedicine, but our biggest players have been pediatric psychiatry, pediatric gastroenterology, pediatric neurology, endocrinology, and general pediatrics. And we've also even seen, we had a pediatric neurologist who needed to move for family reasons to a different state, and they actually continued to see patients for 6 months via telemedicine only clinics to kind of not leave as abruptly, which was interesting to kind of see that be a possibility, even though it wasn't before. Okay. And then looking towards the future, we did survey all of our providers who've done at least one telemedicine visit. We surveyed them about a year ago, and about 37% responded. So we had 1,300 providers responding, and this is across our whole system, so not just pediatric specific, but we asked a couple of questions. How often do you feel you can provide clinically appropriate high quality care via telemedicine in comparison to in-person visits? And for new patients, that median average was 37% of the time, and for established patients, it was 70% of the time, which we thought was pretty high. And then we asked what percent of your schedule template would you like to have open for telemedicine visits? And the median was 30% after the pandemic. And then to drill that down to pediatrics, so this is that same question. How often do you feel you can provide clinically appropriate high quality care via telemedicine in comparison to in-person for established patients? And this is, we grouped the specialties and the labels you can see at the bottom, and then we have box plots, which shows the mean as the black dot, the median as the line in the middle, the 25th and 75th percentiles going on either side, and then the range. And the point of this is to show that, you know, maybe there's a trend that surgeons think it's less clinically appropriate than psychiatry here via the mean and the median. There's a lot of variability in every department. So, and in pediatrics, you know, there are some people who think it's never 0% clinically appropriate for established patients, and some people who think it always is. So we've been told this is similar to the early EHR literature that, you know, when electronic health records were first coming out, some people were gung-ho and really just so in love with it, and some people didn't want to have anything to do with it. So it's really indicating to us that we need to understand the behavior of the champions, so the people who want to do it and feel like it's useful, and kind of helping to make them as successful as possible. And then this, again, that question, what percentage of your schedule template would you like to have open for telemedicine visits after the pandemic, assuming continued reimbursement? This was 1 year ago. And for peds, the median response was a little bit under 20% of the time, or 20% of schedules, but some people wanted to continue to do a ton of telemedicine, whereas others didn't want to do anymore. So in primary care, a group of us have a grant for the Robert Johnson Foundation to try to understand what was the value in our clinics. The first 3 months of the pandemic were such a blur, but trying to understand, at least in our 2 pediatric primary care clinics here, which serve mostly patients enrolled in Medicaid, what types of visits occurred, and also interviewing patients and families to understand what was the value to them. But in my clinical practice, I do see a lot of value. I don't think it's for everything, for sure. You cannot give your baby vaccines, you can't take a weight, you can't listen to a murmur unless you're using a remote stethoscope. But there are some benefits sometimes for things that you can't do for an in-person visit. So for a patient with asthma or with an inhaler, you can see if they have the inhaler in the house. You can watch them take it. You can see the counter on the inhaler. And often patients aren't bringing their medications into clinics, so it makes that medication reconciliation process go a little bit more smoothly. For teenagers, sometimes there's a tendency to talk to the parent when you're in the room with the parent and the teen, but when a teen is given the device, you have to talk directly to the teenager. So sometimes it facilitates a type of communication that may be a little more personal. For nutrition, you can look into families' refrigerators and ask them about what they're eating. Sometimes you can see the meal that they're eating right there. And then for safety issues, talking about safe sleep environments with babies, there's nothing quite like just being shown the baby in the crib and seeing, are there stuffed animals there? Are there heavy blankets? And being able to give that feedback in real time. I don't have to go through these too granularly, but just to say that the Yale primary care pediatrics curriculum is freely available, and they have a rundown of kind of different types of common general pediatric conditions and the pros and cons of doing visits for those conditions over telemedicine. And so I won't run through these too much. I'm happy to provide these slides, and I think the reference might be available, but to me, a lot of it comes down is you're comparing telemedicine care to in-person care, but you're also comparing it to no care. So if a person or family member or patient is not able to come at all, is it better to do a video visit and with their abdominal pain and have them jump up and down and really be reassured that they don't have appendicitis, at least give them some guidance, even if you cannot do that full abdominal exam, and then offering them the anticipatory guidance to come back if needed. And I think particularly for mental health conditions, we as pediatric primary care providers are needing to more and more management of ADHD, depression, anxiety without the assistance of child psychiatrists, because there are so few of them that for mental and behavioral health, even as a pediatric primary care doctor, it's really a helpful tool. And then for asthma follow-up as well, since we're supposed to be seeing patients usually every 3 months to follow up with their asthma if they're on a controller medication. Okay, I don't think I see any questions yet, so I will keep going if that sounds okay, but if anyone wants to pause for questions, please let me know. So my role at Hopkins in our Office of Telemedicine is actually not specific to children. It's really for the health system. And so I spend a lot of my time talking about adults and Medicare beneficiaries in particular, because they are often the most frequent patients. So a lot of the conversation is around adult access. But in my clinical experience, I do feel like kids often have lots of barriers to getting care. Many kids are insured by Medicaid and may have financial barriers to receiving care, transportation barriers for families, missed school days, and just juggling the chaos that is being a parent and having young kids, which I know myself. And then pediatric specialty care is highly centralized. So I did do a month at the Tuba City clinic in the Indian Health Service, and they are 4 hours from Phoenix, which is the closest tertiary care center. And just, I mean, you guys would know better than I am because you're in a bigger state than I am, but you know, it's a huge barrier to have to spend 4 hours going to and from an appointment. But even though I'm in the mid-Atlantic and it's more compressed geographically, there's still a big barrier for someone who lives, you know, on the eastern shore of Maryland, which is 3 hours away, getting to and from their follow-up appointments. And then for kids, they're, to me, a little bit vulnerable because there is no federal approach. So for Medicare, it has not been decided yet what's going to happen for Medicare. But whatever happens, it will apply across the country. But for kids, it's really up to each state's Medicaid program to kind of figure out in the future what's going to be covered. So I will talk a little bit about what I think should happen in the future, just my perspective and kind of my vision for what I would love to the future to look like for pediatric telemedicine, and then we can go to questions, which would be great. But in primary care, to me, a key problem is that the current healthcare financing really rewards volume, you know, fee-for-service visits over value. And there are these competitors in the market who are offering really convenient care, like, you know, Amazon's developing offerings. There are health insurance companies who are developing their own offerings. And so the pediatric primary care medical home could be becoming sort of out of date because it's not convenient enough to access. So I would love to see in 2 years that video visits are still commonly used in pediatric primary care offices, and particularly to expand care to after hours or before hours or weekends when maybe patients need more access, but it's a lot of overhead to kind of have staff at those after hours times. I'd love to see e-consults or asynchronous messaging between providers and teleconsults or provider to provider synchronous interactions to help PCPs collaborate more with specialists and keep care in the medical home when possible. And also that if there are more alternative payment models that are more value-based, that might spur innovation to kind of do the most convenient, low-cost thing for the patient without necessarily bringing them in person. And then hopefully in 5 to 10 years, there are really more capitated payment models that allow for innovation in primary care, and that patients can really receive the most convenient, lowest cost care that's clinically appropriate, whether that be through messaging, phone, or video, and that PCPs are empowered to co-manage their patients with specialists who they have more access to. And really a pre-COVID example of this would be the Kaiser program. So this is from 2017, this graphic showing how much telehealth activity they had. And they've actually had a lot of growth in their telehealth activity in COVID too, but speaking with one of my former co-trainees who works at Kaiser, you know, it's a very different model for her. She is able to submit an electronic consultation to ask a question to a specialist. If that doesn't get the answer, she can schedule a next day video visit with that specialist. If that doesn't get the answer, she can send her patient in person. But you know, she's really able to get the most advice to manage her patients before sending them on to additional care. For pediatric behavioral health, we have a huge problem that there's an accelerated need for pediatric behavioral health services, but a really significant workforce shortage. So my hope is that then in 2 to 3 years, we continue to see a lot of behavioral care over video and have better patient uptake. So our personal child psychiatry has found a lot higher show rates for their mental and behavioral health visits when doing it by video, and still are doing a lot of care by video. Hopefully there's more 24/7 emergency psychiatric care for children by video, which hopefully would decrease ED use and ED boarding. We have a lot of problems with children spending 24, 48, 72 hours in the emergency department while waiting psychiatric bed placement. And so if that person could be evaluated and placed more quickly or get outpatient services quickly, then that wouldn't be taking up really needed ED beds. And that e-consults and teleconsults help facilitate more collaboration where PCPs can access the advice of mental behavioral health providers. And that in 5 to 10 years, there's a lot more telementoring programs like Project Echo that train the pediatric primary care particular to meet this really epidemic of pediatric behavioral mental health issues. And that telepsychology can be integrated in the medical home so that you can connect patients and psychologists directly. And that really child psychiatrists would be will practice at the top of their license to really manage the refractory cases that can't be managed in the medical home. And a pre-COVID example of this type of model would be a Project Echo we have here at Hopkins, which is called KKI NECT Echo. So Kennedy Krieger Institute is a institute for patients with developmental disabilities, and they have a developmental pediatrician and child psychiatrist there who launched this Project Echo for help pediatricians care for children with developmental and behavioral concerns, which was aimed to target rural areas in Maryland and West Virginia. You are a Project Echo sponsored group, so I imagine you have a good background in this, but like other Project Echoes have this hub and spoke model with the hub of the neurodevelopmental pediatrician, developmental behavioral pediatrician, child psychiatrist, behavioral psychologist, and social workers, and then the primary care providers at the spoke sites who are caring for the patients. 96 of the cases that had been presented over the first 2 years of the program were be able to be managed in the medical home without needing to come to Kennedy Krieger for care. And this particularly focused on early childhood mental and behavioral health, so like under 5, which is a particularly difficult time in terms of medication management, because often general pediatricians are not comfortable with that for children that young. So they had seen pre-COVID, one provider who participated said, when you asked me to participate, I was worried I wouldn't be able to commit an hour a week. And now it's the hour in my week I most look forward to. And another said, it makes you feel like you're not alone in the world with the multiple roadblocks delivering good mental health care as a general pediatrician. And then finally, in specialty care, pediatric specialty care can be really difficult to access in terms of needing to travel and wait a long time for a visit. And some states actually lack a specialist to care for children who have rare conditions. So we have a metabolic geneticist who cares for patients in Delaware, and Delaware does not have a metabolic geneticist. So these patients with these really rare metabolic conditions cannot receive their care in Delaware. So it's very frustrating to her that the pre-COVID licensure issues have gone back in place because a lot of their care she could be managing over telemedicine and they wouldn't need to travel all the way from Delaware. So my hope for specialty care is that video visits remain accessible when clinically appropriate, and that e-consults and teleconsults help facilitate more collaboration between PCPs and specialists and really reserve the in-person specialist time for patients who really need their specialty advice and triage those other concerns to stay in the medical home. And that hopefully in 5 to 10 years, there are more established guidelines to understand when things should be in person, when they should be by telehealth for specialty care, that there's more remote patient monitoring for chronic conditions, and that there's more collaboration across institutions to form care networks and to address cross-state licensures issues for patients with rare conditions. So, the Veteran Affairs Group has a really robust program where any veteran can see any VA provider across the country to really improve their access to care. And I'd love to see something similar for children with rare conditions, because it's really such a shame that their families have to travel so far to find a specialist who sees patients with their rare disease. So if you're interested in growing more pediatric telehealth, you obviously are connected well in that you have the TexLa Telehealth Resource Center here to help you. Ours is Matrix, which is the Mid-Atlantic Telehealth Resource Center, and the resource centers are great groups of experts who were often doing this pre-COVID, and so have the perspective of what the barriers were. I do worry as things go back to normal, there won't be as most robust interest, and we're going to be back to kind of trying to figure out how we can continue to push for convenient care for patients, but navigating, provider burnout and making it easy for providers as well as making it financially sustainable. And then the Center for Connected Healthcare Policy is another great resource. They have different topics, areas, as well as state level information. It's very complicated, sometimes people, when I tell them what I do for my administrative job, are like, well, isn't it just, FaceTime with your patients and don't really understand how complicated it is. But, there's a lot to keep up with, and it's all changing so quickly because of COVID that it's great to lean on the resources that people who have a lot of expertise at your institution. And then you guys will have to update me because you'll know more than I do, but we spend a lot of time here in Maryland thinking about what's going to happen with Maryland Medicaid. So for us, what happened was they passed the Preserve Telehealth Access Act of 2021 in April of 2021, which basically said everything will stay the same as it's been during COVID until January of 2023, so this January. And they commissioned a study with the Maryland Healthcare Commission to ask, what's the deal with telehealth? Did it work? Was it high quality? Did it worsen disparities? So the Maryland Healthcare Commission is doing that study now, and we're like furiously writing emails and offering to meet with people to show them our data, try to help them understand. It looks like you guys have a rule being posted this summer for public comment. You probably know way more than I do, but it's really powerful providers who have actual stories about actual patients. And Medicaid, obviously it matters for all Medicaid beneficiaries, but it's really important for children. At least at Hopkins, I think 50% of the children we see are insured by Maryland Medicaid. So like whatever happens with Maryland Medicaid is going to drive the telehealth we offer for kids in Maryland. So, when people ask, like, is telehealth here to stay? Unfortunately, it seems just to do with ultimately the money and what can be reimbursed. And that, depends on multiple things. So from our perspective in Maryland, private insurance companies already covered this pre-COVID. So Blue Cross Blue Shield was not an issue. We could have been doing this then for Blue Cross Blue Shield patients, but we couldn't because it wasn't easy to do it for all patients. We're working with Maryland Medicaid to understand, and Maryland legislature to understand for Medicaid, can we keep audio only, or does it need to go back to audio visual? Can we continue to reimburse at parity, which we were a parity state pre-COVID, getting the same amount if the same care was delivered? Can we still have patient and provider location flexibilities? Can we still have our, occupational therapists or other types of therapists, nutritionists doing telehealth, or will it go back to just being providers? And what are the licensure issues going to be cross state? And then, we're trying our best to speak our loudest voice about what's going to happen with the federal government. So for the federal government, it's just still in this public health emergency state, which means we are still in the same waivers that we've been in this whole 2.5 years. When the public health emergency ends, which I think the soonest it would end now, they're supposed to give 60 days notice and they haven't. So the soonest it would end now, I think, would be September. And once the COVID public health emergency ends, they passed an omnibus legislation that the telehealth waivers will continue another 151 days after that. So I think we will live in this current state for Medicare beneficiaries until March of 2023 at the earliest. But we obviously have a vested interest because this is our jobs, but from a patient access standpoint, just want to be able to continue to offer visits to patients in their homes. So there are a lot of great groups that were active in pediatric specific telehealth world pre-COVID. AAP Sprout that I mentioned, and John Chu from CHOP is the research director of that group. They are really active. They have like a listserv, and they used to have an annual meeting, and they're active at the AAP conference. There's the AAP section on telehealth, who's led by David McSwain at MUSC. And then the American Telemedicine Association has a pediatric telehealth interest group led by Joey McElliott, who's also at MUSC. So I think that is all I have, but I really appreciate connecting with you guys and for the invitation. I'm happy to have any questions or discussion.
Comprehensive discussion. Thank you very much for that comprehensive discussion on pediatric telehealth. I learned a lot, from your presentation, and thank you for taking some time on researching on our own state about telemedicine as well and the new laws. And I'm with you that hopefully we still have the audio, and hopefully we'll improve with our broadband access as well, which is a problem here in the big state of Texas. I'm still wanting to have to make sure we have the multidisciplinary access, not just for medicine, but as well as for social work, nutritionist, dietitian, pharmacist to be included in the offering of that telehealth. And I think Texas last March joined the compact. So we're getting there, and hopefully this will be a federal, mandate eventually that everyone could practice wherever you are, so the patient who is probably trust, Dr. Hughes, whether she's in Maryland or in the congruent state, could able to see those patients, right? The other thing though is I would like to start the question, Dr. Hughes. We have a bunch of parents here as well in our audiences, and there are those who are advocating for telemedicine because it's so convenient. They don't need to have a time off. They could just schedule a telehealth or telemedicine visit. However, there are skeptics who says, well, how could you do physical examination? How safe and effective the telehealth visit? Will it replace the brick and mortar clinics we have, or is this just an adjuvant or an adjunct to the delivery of pediatric healthcare?
It's definitely not going to solve everything or be a tool for everything. So I'm a parent in addition to a pediatrician. If my child has a fever and I can't figure out what's going on, like, they need to be examined in person. I do have a Tyto kit, which I can explain to someone else what that is, but my provider doesn't use Tyto, so I can't really use it to have them look in my child's ears. I can look in his ears because I'm a pediatrician, but I really should take him in and be evaluated. He might need a urinalysis or urine culture, and a lot of those things are just, even if you could do it remotely, it's hard to operationalize. So sometimes the best and most convenient care is going to be coming in person. I think it's also nice to establish a relationship with a provider in person. Like, there is nothing like meeting someone in person. So I certainly don't think brick and mortar pediatric primary care, which is what I practice, will go away. I think probably yearly visits should continue to be in person. Like, there's nothing like a full physical exam to really identify an issue, getting a height and weight that is accurate. Building that relationship. But for a lot of follow-up care, whether it's a patient had an asthma attack, when a patient has an asthma attack and they're in the hospital, they're supposed to come back to clinic, within 3 days for hospital follow-up, and then you're supposed to kind of wean their steroids and see what they need. And then sometimes we're supposed to have them come back the next week to see how they're doing then. A lot of those further follow-up visits for chronic conditions, I think a lot of what you're doing is history taking. And so many of those visits, you're going to probably get like 80% of the benefit by seeing the patient over video. And then I have a son with special needs, and he has some specialists, and some of them don't need to do procedures or tests or labs. And it has been unbelievably convenient to do those visits. Even we live in Baltimore County, which is like 30 minutes away, but for me to get off of work, get him from school, come back down here, park, I have to take an entire day off of work, versus if I can schedule it for 4 and I know he's done with school and I'm working from home, it literally saves me like 5 hours. And if you have a kid who has to have monthly visits, it's like a big deal. So I would just say it's not a one-size-fits-all solution. To me, it's not going to replace in-person care, but it's really about what is feasible for the patient, what is clinically appropriate, and what is the provider comfortable doing.
How about Dr. Hughes, those pediatrician that is still kind of skeptics? How do you convince your colleagues at Hopkins, to take telemedicine? Because we're trying to do that in some of our, colleagues here at Texas Tech as well.
Yes. It's tough. Like, it's a hard time to be a person and a doctor and a parent, and people have a lot of things on their plate, and to say like, yes, you're comfortable. I'll take an example. My mom's a physician, and she had to retire when her her institution went to electronic health records. Like, she was used to dictating and she was used to doing notes on paper, and it literally took her an extra 3 hours a day. And so like she retired early because she couldn't do it. So I would hate to see, providers who hate it be forced to do it and then be miserable at their jobs. I think similar to, the EHR rollouts, probably there will be a time when it's part of what everyone does. But at this exact moment, I think we're still, as I showed in that graphic, in the kind of champion stage. So we don't have any sort of requirement that everyone has to do X% of telemedicine or everyone has to have X% of telemedicine on their schedules. We're more letting providers, divisions, and departments like innovate locally. So some of our divisions have chosen to hire virtualists. So for specialties that maybe have conditions that are amenable to telemedicine, like neurology, they may be hiring someone who's like 100% virtual or 50% virtual, and that person's going to be doing e-consult messages and doing video visits and really offering that telemedicine access without needing to require that every single provider do a certain amount. Which has risks and benefits. What if that virtual person needs to see a patient in person? I don't think it's a perfect solution, but it's kind of how we're approaching it for now.
Well, I'm still, amazed that in your census, it seems like more than 12% of your clinic visits are telemedicine. So that's a good amount, Dr. Hughes.
Did you say 12%?
Yeah, more than
yes.
12%.
Yes.
Yeah.
So that's across all of pediatrics. So I'd have to then drill down further into pediatric specialties versus pediatric primary care. I think probably we're at about 10% of our pediatric primary care visits, and most of those are follow-up visits or acute care visits. And then pediatric endocrinology is still doing a fair amount of telemedicine because a lot of their diabetes follow-up, they have a glucometer that they can upload to a portal. A lot of it is discussing symptoms. So we're finding some of our specialists for specific conditions are still doing a lot of telehealth.
Right. Well, I would like to thank Daniel Stewart for putting in all your reference there in our chat box. I don't know if you noticed that, but we have a comment.
Yes, thank you so much.
Yes, no, thank you so much. Dr. Rodriguez had a comment. Thank you very much for this informative and well-organized talk. I learned a lot and wish the best for telemedicine in the future. And Laura Lapi says, I would like to see e-consult prosper in the telehealth space. And I would like to ask, how are you using or leveraging, school-based telemedicine? Because right now, you probably heard what happened in Uvalde, Texas. A lot of, heartache going on,
yes.
With the school shooting and whatnot. And they actually using the school-based telemedicine, to help with the behavioral health of our students there in Uvalde, Texas. One of my hopes in the future is we could leverage, school-based telemedicine to deliver and do some screening. Some of our colleagues, actually speech language pathologists, are doing some screening in stuttering and, hearing problem. But hopefully this will go on, screening for depression, screening for well-being of our and wellness of our school children.
Yes, absolutely. I mean, it's so important. Probably the Medical University of South Carolina. So the paper that that was chatted from Medical University of South Carolina program, they have a really long-standing, large statewide school-based health program. We explored it pre-COVID, but our state was going to require us to make each school that had school-based telehealth a school-based health center. So like in Baltimore City, of the hundreds of schools, only 10 have a school-based health center. And the state at that time was going to require that we go through the expensive process of making any school that's going to have telehealth a school-based health center. So that was like a really difficult barrier to entry to go through the expensive process. I think now that people have experienced it in their homes and their lives, there's a lot less fear of it. And I would hope that it will be easier to do. But that Medical University of South Carolina program had a much bigger emphasis on rural health and underserved populations. And so they're a great example to look to. And from the parent side, one of the problems becomes making sure the parent is included in the care. So yes, you've got a 10-year-old there in the school, but how do you triangulate with their parent? Because really you need their parents' permission and their parents' involvement to treat them.
Or they could be included in the telemedicine or telehealth visit, right? The parents.
Totally, as they should be. But sometimes even that is challenging. Like we have a lot of patients whose phone numbers are not accurate, and it is very hard to get people in touch with people on the phone. So that was sometimes a barrier and sometimes not. But I think there's a lot of potential, particularly for mental and behavioral health. And it would be, but I kind of look to South Carolina as one of the states that's led the way in that.
Yes, MUSC is one of the Center of Excellence in telehealth. I have a great question here from George, from Kirtana George. Great presentation, Dr. Hughes. I was just wondering how telemedicine education is currently incorporated in pediatric training, if there are plans to incorporate it more in the future.
Yes, thank you so much. So currently we have, we use the pediatric education ambulatory curriculum. I think it's called PEAK, which is put out by Hopkins, actually available to many institutions. I'm happy to provide the information for others who are interested. It's a subscription service, but we have a telemedicine PEAK module that all of our residents do. So part of it is kind of a module-based format. I do a once a month teaching session with our residents when they're on their ambulatory block rotation to talk. It's mostly about some of the technical aspects, but also some of the clinical aspects. But it is a challenge. I mean, I think the understanding how it should be incorporated in the medical school curriculum, whether there are standardized patients and clinical skills evaluation that are by telemedicine. We did develop a brief video curriculum as well. This is not pediatric specific, but for medical students, a video curriculum and a coaching session. So I think we really do have to think about it across the continuum, but the challenge is often the faculty may not be completely comfortable. So you're kind of learning side by side. And sometimes the residents are more comfortable with the technology than the faculty are. So there's like a hand-in-hand learning together. But I know, I think it's Nicole Paradise Black out of University of Florida has a big a pediatric training curriculum. So I think there are a lot of good people who are working through what are the best practices for teaching in pediatrics, specifically telemedicine.
But that is a great question, Kirtana. I love the question. And AAMC put out a competency as well regarding, telemedicine, but it's very generalized, not specific to pediatrics. And I'm actually chatting with our Associate Dean of Medical Education here at Texas Tech to include telemedicine as part of the OSCE, examination. So they get used to telemedicine encounter. How about Dr. Hughes, your colleagues? Are there training for colleagues for attendings? Because during my med school, definitely there's no telemedicine.
Yes.
During my training, there's no telemedicine. So suddenly we're just doing it. So
Yes.
How could we keep up to date on how to do it effectively and based on practice-based guidelines?
Yes, absolutely. Well, I think you were in attendance at a symposium we had back in March.
Yes.
So we had kind of an event at Hopkins that was open nationally, just to essentially start a little bit of the conversation more. We have developed some resources that we're right now targeting to students, but really could be used by faculty and attendings as well. I think the hard thing is when you're out of training, you're often kind of out of sync of that mindset of like, oh, I need to learn this completely new thing. Certainly CME is an avenue for everyone needs to get continuing medical education credit, and how could there be easily packaged activities that could be available for faculty. But we're trying to have resources that can be targeted to different groups. And then also part of it is just is practice. So those champions who've done a lot of telemedicine, they've learned a lot over the past few years. We have a substance use disorder expert in psychiatry who's done like 7,000 telemedicine visits. So he probably has a lot of skills. So how can you leverage those people who now have a ton of outpatient experience to train others and train those in their divisions and departments?
So we talk about educating or training our providers. How about educating our patients? I think that's very important as well, because sometimes they are probably have some digital divide, some of them probably are not used to technology, and so how could we do education to our patients and
Yes,
their
yes.
caregivers?
Yes, it's so important. And the AAMC actually has a subcommittee on telehealth and healthcare equity that I'm pretty active with. It's a really great group. And certainly part of it is education, but there's I think a broader term arising called digital inclusion, which is the education part, but also the design part. And like, how do we not only teach patients what's available, but make what's available accessible to patients, kind of on both sides of the coin. In the rapid explosion during COVID, it was kind of fly by the seat of your pants, tip sheets, training videos on YouTube for patients. There's often a barrier to just trying something new. Like when I download an app on my phone, sometimes I don't open it for 6 months just because I'm like, I don't know, this is new. We're trying to think about how do we, we're talking with our Office of Economic Development at Hopkins, as well as some community-based partners for just like general digital education resources in the East Baltimore community, which is near Johns Hopkins Hospital, with undergraduate volunteers. How can we offer services to teach patients how to get into a tablet, how to set the font the way you want it, how to get into your email, just some of those basic digital use skills, and then build onto that. What is a patient portal? Because some people really love MyChart, and we've seen, as you may have, if you have a patient portal, like exponential logins and use of the patient portal, but there's still people who are really hesitant. So how can we offer, in-person training resources as well as remote training resources so patients can learn the way they want to learn?
That's great. Taja, do you have any question for Dr. Hughes?
Well, first off, I just want to say thank you so much for a great presentation. It was very educational, and I appreciate the insights that you gave with the data from the different institutions. I did want to remind everyone to please fill out your session evaluation surveys to obtain the CME credit. And I know we're getting near the end. So I also want to let people know on July 7th, we'll have another unique telemedicine webinar. And this time it'll be on trauma-informed care. And it's going to be presented with the ComBest Institute. This was a wonderful discussion. And I'm excited for the future of telemedicine.
Thank you again. And Dr. Hughes, we're presenting you this virtual challenge coin. We're gonna mail you our challenge coin. And thank you very much, for this wonderful presentation. I learned a lot. And in behalf of Dr. George, who is currently sick right now, but who is usually my co-moderator, we would like to present you this challenge coin for the wonderful talk and your wonderful work as a leader, researcher, and clinician, and one of the pioneers in the field of pediatric telemedicine, and most importantly, for using digital health, improving access of care and quality of care, especially among underserved patient population. Dr. Hughes, thank you so much.
Thank you very much. It was great to meet you guys there in Texas, and hope we stay connected.
Absolutely, we'll stay connected. Thank you. Okay. Thank you, everyone, for attending this telemedicine webinar.
Thank you.